excited. The next session with the focus on public health genomics is exciting to me, and I am honored to introduce our next speaker, Dr. Guan, who's an associate professor in Rollins School of Public Health at Emory University. She's also a co-investigator with me in the co-propel grant. Today she's going to talk to you about a multi-level adaptation approach to expand a statewide cancer genetic risk screening program. So please join me in welcoming Dr. Guan.
Thank you. Thank you for the introduction. So I think I need the correct slide deck. Thank you. Again, my name is Guan. It's my great pleasure to be here today and share our research projects talking about how we adapted a statewide cancer genetic risk screening program. Even the context is in cancer genetics, I'm hoping our multi-level approach and how we apply the implementation science theories can be applicable in other population-based screening programs, such as newborn screening or screening for other inherited conditions. I would like to first acknowledge our team. This project is a collaboration between Emory University and Georgia Department of Public Health, and our local community partner, Horizons. And the project was funded by NCI. And I always want to start talking about the broader context of our research work. As you all know, in the past 2 decades, we have made great breakthroughs in basic genomic discoveries. However, if we look at the translation work into clinical settings or public health settings, the pace has been extremely slow. And when we talk about translation, I think people in the public or people even in our field are more familiar with clinical translation, for example, genetic counseling. We know one-on-one genetic counseling service can be highly effective to improve patient understanding, change their behaviors. However, it can also be resource intensive. If we look across the country, there are only about 7,000 certified genetic counselors. In the state of Georgia, most of the genetic counselors are hired by large medical centers. They are working in metropolitan areas. So there has been limited resources to allow genetic counseling to be scaled up or reach rural areas. So the overall population impact could be limited. In comparison, if we look at public health settings, we know if we want to do anything at the population level, it has to be low cost and low touch, and we have to rely on existing infrastructures. But because we have a population level reach, even sometimes the effectiveness size could be small to moderate, but there is a potential for significant population impact. So my research program and the work I'm going to present fall under this category, how we can translate genomic discoveries more effectively at the population level, especially relying on public health infrastructures. So today, I want to focus this case in genetic risk stratified cancer screening. We know there are evidence-based guidelines and policies to promote the use of family cancer history screening at the population level, like CDC Tier 1 recommendations, to allow us to stratify populations. For those people who screen to be positive or at high genetic risk, they are recommended to see a genetic counselor and consider genetic testing. At the same time, we will automatically identify a large proportion of the population who are at low genetic risk. They could benefit from learning about this information and consider how to do their cancer prevention options. Maybe they need to follow routine cancer screening, or they need to consider more advanced screening based on additional risk assessment. So a few key considerations I want to highlight here. If we really want to achieve the ambitious goal of public health genomics, to do that, we have to make sure, consider the whole population. We have to incorporate public health perspectives. we need to make sure everyone, either at high or low genetic risk, they need to understand the implications for their cancer risks and guide their cancer prevention options. The second consideration is that we need to shift our focus from clinical translation to think about how to make our screening efforts sustainable and can be scaled up. And we also need to anticipate disparities in access. And also another consideration is that we cannot view genetic risk screening as a one-time thing. It could be a teachable moment, but we have to consider the broader care spectrum. After the screening or after genetic testing, we need to think about how to ensure patients have access to appropriate follow-up care, risk-stratified follow-up care. So I know like these considerations may not be new to people in this room, but if we look at the broader cancer genetic implementation work, there has been limited implementation outside the traditional oncology or especially clinical care settings. We did a systematic review to look at initiatives implemented in these non-traditional settings. As you can see here, we started with almost 18,000 articles and only found 16 programs met our inclusion criteria. And 11 of them were still done in clinical settings, such as primary care or community hospitals. Only 5 were done in public health settings, such as cancer registry, national or local healthcare call centers. We did a very rough estimation to look at the program reach. So it shows that programs relying on public health programs have a relatively higher target population reach. So even though it's not like very strict, very confined estimation, but it shows the potential if we can look more opportunities in public health. Among those programs, the program I'm going to talk about today is the Family Cancer History Screening Program in the state of Georgia. I think the state of Georgia is among very few states has implemented a statewide family cancer history screening program in public health clinics across the state. So if you are unfamiliar with public health clinics, these are clinics similar to FHQC clinics. They are serving largely medically underserved areas, serving patients who are uninsured, low income, and living in poverty. We did a 10-year program evaluation. The program first started in 2012. We can see the program has been quite successful. Currently, it covers more than half of all counties in the state and screened more than 30,000 women. Majority of the women who undergone this screening program self-identified from a racial ethnic minority group. However, if we look at the whole population, all the age-eligible women who are being served by these clinics, only a small proportion of women have had the chance to go through this process and learn about their cancer genetic risks. So there's a great potential for improvement. But if we want to increase program reach and screening uptake in these resource-limited settings, we have to make sure everything we do are sustainable. Even we get research funding. After 5 years, 3 years, after the funding ends, we need to make sure the intervention strategies can be maintained in these clinics and carry on. And also we need to find more effective strategies to engage rural communities. And like I mentioned before, we need to incorporate public health perspective, really think about health communication, how to make sure everyone can understand their genetic risk implications. So we received funding 2 years ago from NCI to support our program Adaptation. We have 2 very clear adaptation goals. The first goal is to increase the number of women screened, and the second goal is to improve communication comprehension for the screening results. And we want to make sure everything we do are sustainable. For these research projects, we are collaborating with the Southwest Public Health District. That district covers 14 counties, and 13 are considered as medically underserved area. And the population is very diverse. They have about 40% Black African American community members, 10% Hispanic Latino community, and about 1/3 are white patients. So to guide our project, we referred to the exploration, preparation, implementation, and sustainment framework, APIS framework. In phase 1, we want to start with an exploration to engage stakeholders from multiple levels, complete our assessment, and help us to develop adaptation components and implementation strategies. And then in phase 2, we will test the adapted program in 6 out of 14 public health clinics in that district to look at the screening numbers, screening uptake, and screening results understanding. And we will also track the risk stratified screening behaviors after they complete family history screening. Specifically for women who screen positive, we want them to follow recommendations to complete genetic consultation and consider genetic testing. And for those low-risk women, we want to make sure they follow recommendations to start mammogram screening at age 40 and just talk to their doctor about their screening plan. And at the same time, we will conduct program implementation process evaluation informed by the RAIN framework. I think you learned about the framework from yesterday's presentation. Again, throughout this process, sustainment was our key consideration. So next, I want to share our processes of phase 1, how we did exploration and preparation to start the adaptation process. So there's some music. This is a perfect place to pause. Because next I will talk about how we conducted the adaptation. To start the process, we want to understand how the screening program is currently being done. We recruited providers from 6 clinics to conduct a workflow assessment. So we want to identify what are the key procedures involved, who was the personnel, where did it happen, location, and as well as what are the key barriers and facilitators. We also did a prospective time study to document time spent on key procedures and a site visit to understand the layout of the clinic, the patient flow. So based on all this information, we were able to create a master workflow diagram to show what happens for women in order to complete the family cancer history screening. In brief, for these women, they have to call to make an appointment for their annual wellness check visit. When they come to the clinic, they will first complete labs in an exam room and then spend 1 hour in a private exam room to complete a very long list the nurse has to complete. And family history is embedded into that process, which only takes about 5 minutes. But because the visit is too long and there's so many other priorities and tasks, nurses usually only have limited time to explain the results. And after the visit, the nurse has to fill out a referral form, scan it into the EMR, and fax it to Georgia Core to complete the referral. And positive screening patients will talk to a nurse practitioner who received special training in genetics for genetic consultation, and the nurse will then coordinate genetic testing. Again, across the entire state, there's only 1 genetic nurse at Georgia Core who handles all the positive screenings. And for negative screening results, given the current resources, there's no time for communication and there's no follow-ups. So I'm sure you already identified a few areas for improvement. And we also have very detailed qualitative summary about barriers and facilitators associated with each one of the steps described here. So next, based on, after we have a comprehensive understanding of how things are currently working, we established a stakeholder advisory committee to help us identify and prioritize adaptation strategies. We have 3 groups here. The first group is internal stakeholders. These are leadership staff and providers within the public health clinic system. We also recruited external stakeholders. These are leadership staff from local organizations, and the organizations are either involved in the upstream of the cancer history screening, for example, community organizations, or they are involving in the downstream care, for example, mammography screening centers and breast surgeons. Again, going back to my earlier point, we want to consider family cancer history in part of the care spectrum in the process. And of course, community members are our third group, women who have or have not had experience with the family cancer history screening. And to identify adaptation strategies, we first conducted interviews with internal stakeholders. These interviews were highly structured. So during the interview, we first presented the workflow diagram and also the barriers and facilitators associated with each step. And then participants were asked to think about what are the gaps and what are the opportunities. Think about strategies to address those gaps. And we also asked them to reflect on unintended negative consequences associated with strategies proposed. For example, one strategy could be, let's text patients about the screening. Let's allow patients to complete the screening at home online because the screening tool is available online. And then one potential negative consequences could be for a lot of older patients, rural patients, they may not be technology savvy, they may not be able to complete the screening online. And also think about health literacy, maybe some patients need more immediate communication support. So again, we are not just interested in the strategy, we want people to think deeper and reflect on, can the strategy benefit all patient population equally? There are no patient groups who may not share the equal benefit from your intervention or program. So then our study team summarized the gaps and strategies, and we developed a prototype adaptation workbook. Here is a screenshot from the workbook. For each key step, we summarized the key major gaps and associated strategies. We also developed evaluation criteria informed by implementation science frameworks. For example, we want to evaluate for each strategy how easy, doable, effective, and long-lasting it is when we're considering our adaptation goals. Following that, we engaged the full stakeholder group, all 3 stakeholder groups, in a large group deliberation process. The deliberation happened online. We only had 90 minutes. So before the deliberation, we shared the prototype workbook for participants to review. And during the deliberation, we broke them into 2 groups. So patients were in one group and stakeholders were in a separate group. Within the small group, they were asked to first select their top 3 strategies for a specific gap, and then they will deliberate on the pros and cons for that strategy and considering all the evaluation metrics. And after that, we bring everyone together in the large group discussion, and they will discuss the differences between the stakeholder groups and provided rationale why there were differences and also why they prioritized certain strategies over the other. Then following the deliberation, we also did a 3-day follow-up survey to have participants rate all the strategies. And the results here, you can see several strategies received high rating consistently across different groups. These strategies were focused on social media and community existing outreach to increase awareness and also expanding the screening in other health programs in the clinic. And all the strategies, they are trying to rely on the existing procedures and consistent with the clinic policy. And strategies received low ratings across groups were required adding more personnel or adding new resources, such as doing mobile clinics or providing transportation vouchers to patients. And interestingly, and not surprisingly, we had mixed ratings on 7 strategies. We can see community members, they favored more on strategies that reduce patient burden. They really hope the clinic can make phone calls or text them or allow them to do the screening outside the clinic visits. But our deliberation, the discussion reviewed concerns from stakeholders. They are worried about staff burden because some clinics, they don't even have one nurse practitioner. The nurse practitioner has to rotate across different clinics. And also the IT capacity and DPH policy, health literacy among the patient population, and also follow-up care. So here, if we, the example is if we allow patients to do the family history screening at home, they will not have an established medical record in the clinic. So then the clinic cannot do follow-up, cannot link the patient to genetic consultation or refer the patient to mammography screening in a timely manner. So we cannot just put all the responsibilities on the patients. So based on all these findings, we were able to finalize 15 adaptation strategies. All strategies were pre-implementation and fidelity consistent, and most of the strategies were responsive to our first adaptation goal to increase the screening numbers, and 2 were improving communication effectiveness. And if we look at the levels of adaptation, most of adaptations happen at the organization and clinic level, because individual and provider level adaptations would require a lot of tailoring and a lot of ongoing support, which would limit the sustainability or skill up, potential for skill up. And most components are about implementation, skill up, and most of the strategies are adding more things to the screening program. So here I want to also have highlight the idea is that we know the policies and funding agencies now they are really promoting multi-level programs and interventions. However, in reality, it's just not feasible to address all the levels and all the factors at the same time. We have to consider the resource constraints. So in this case, it is very important for us to incorporate a multi-level lens in our community assessment when we're assessing the problem, but it is equally important to have this very systematic process to prioritize which level we should target for this program and which factors should be prioritized. So in this way, we will be able to use the limited resources we have to maximize the potential effectiveness of our program. So next, I want to briefly walk you through how we optionalized these adaptation strategies. And we'll go use the workflow diagram as a guidance. So before women encounter with the clinic, we added, for the adaptive program, we added a lot of outreach activities. Again, these are not new activities. We just want to be included in the ongoing DPH community outreach events. And we were also able to convince the leadership in the clinic to expand the screening to other health care programs in the clinic except for childcare. And here are some social media posts we developed. One is more generic, and every month, depending on the theme, we will have more thematic posts posted. And in the last month, in June, we were able to participate in 3 community outreach events. We just set up a table and have our materials available. And the current new landing page briefly describe why the family cancer history screening matters to them, what will involve in the visit, the costs associated with the visit, the genetic testing, because this is a very important information patients want to know. And also how to make an appointment, what they can say, the script they can use when they are making the appointment. Again, the website, everything we do are directing patients to the clinic. We do not encourage them to complete the screening by themselves. And then during the visit, administering the screening, we embedded the reminder banner in the EMR system, and we removed a lot of unnecessary data collection. I think as researchers, we love more data. We want to learn more about the patients. So it was a long process to reduce the data collection to the minimum. We only need to collect necessary information to complete the screening and to understand our patient population. And also importantly, we maintained the in-person interaction because that's a core fidelity for the screening program. And we also created a clinic-specific screening link. So in this way, the nurse doesn't have to fill in their clinic information every single time, and also reduce human error. So when it's possible, we try to make the process as automatic as possible. And for result discussion and documentation, we simplified the process and also developed theory-based communication messages, both online and print versions, to facilitate result understanding, both for the positive results and negative results. And after the visit, we developed automatic referral system, so there's no more faxing, no more scanning, and consolidated the tracking system from 3 into 1. And again, in order to respond to patient needs, but also follow the DPH policy, we shifted the automatic communication from the clinic to Georgia Core. After patient consent, they will be able to receive planned, scheduled text messages about their screening results, what are the immediate actions we want them to take, and also 1-year follow-up. We want to encourage them to continue mammogram screening. So here are the screenshots from the web page for the positive screening results. The videos we included were also previously tested in another project, and the content is specific for that community and specific for the Georgia Course screening program. And the print materials, the wallet card is one example. We want something the patient doesn't so easily to throw away. So we have very brief key information about their results and also what are the immediate actions we want them to take. Okay. We launched our clinical trial in February this year, so the trial just got started. I'm hoping to be able to report more results in the future, but we already see a positive trend in terms of screening numbers. And we're in the process of analyzing some preliminary data about result understanding. In summary, I think some key messages I want us to start thinking or discussing are, if we want to adapt an already existing population-based screening programs, such as a state newborn screening program, we want to make it better and more sustainable, it will be important for us to engage stakeholders from multiple levels into that process to help us prioritize what should be our adaptation components. And also, it is important to have a parsimonious consideration to think about, given the limited timeline and limited funding, which strategy we need to prioritize. And at the same time, it is important for us to think about the potential unintended negative consequences for certain subgroups of our population. We want to make sure the program, anything you develop, can benefit the whole patient population. Okay, so that concludes my part. I think we have a lot of time for questions.
Thank you so much, Gwen, for a very, very nice talk. And as a genetic counselor and a social behavior scientist, taking this to the population level, you know, your work and showing the intervention, it's a great step for us all to think. Any comments or questions from the audience, or any other experiences in the audience that anybody would like to comment on? No? Well, you know, I'm very impressed with the figures you talked about, the reach and the impact factor by taking this approach. And so we can reach the communication at way larger number, even as a whole as a population, rather than only doing things in the clinical setting. How do you see this apply to the newborn screening diseases we have been doing? Do you see the potential for that for us to go for population-based education, or to reach a higher number to start educating about genetics or specific genetic diseases?
Yeah, definitely. I think when we think about communication to the public versus to patients, we have to balance what content is most relevant to the entire patient population and what are the very brief and key behaviors we want them to take. So we may not be able to do a lot of tailoring. We cannot really understand the individual patient's interest and their preference. But if for our entire patient population, identify what are the key messages they need to understand, identify what would be the platform that can reach the most population, the community, would be very important. And I think that's the value of bringing public health researchers and practitioners into our work and help us disseminate the important messages we want all the patients to understand. And yesterday, I think we also started discussion about potential to have whole genome sequencing incorporated into newborn screening. I know there are several research projects in the US and in UK. Again, the approach they are taking, like in how to incorporate genetic counseling into the result discussion or even in the consent process, that's also like something we need to think creatively. We cannot rely all the Department of Public Health hire more genetic counselors, but figure out what communication can be taken over by public health approaches versus what communication is better and more suitable to be addressed by a genetic counselor.
Yeah. So I think one of the challenges I have always wondered is, even working with HRSA, we have not even won the battle of talking about newborn screening population-based. You know, like a lot of patients, when they test positive for the screen, and I asked them, they had never heard about, they were not even aware their child was going to be screened, at least, or the positive cases there. Do you think, before we start talking about whole genome sequencing and all, but you were talking about newborn screening. Anybody has any thoughts? Or because I feel like that's a challenge in itself, because many mothers don't even know that their child was going to be screened. Tracy.
Hi, good morning. Tracy Bryant, Mississippi State Department of Health. Thank you so much for a wonderful and elaborate overview of breast and cervical cancer. As Dr. Singh mentioned, just the collaboration and understanding how all this links together, do you propose, with all the education that's out there, connecting this to newborn screening in a way where there's a registry that for patients that have been diagnosed with cancer and they have family members with that to possibly be a carrier as an infant down generations, that can be a flag on not so much as, I know you gotta do HIPAA and all the different areas, but connecting that genetic line. Could that be from grandparent to parent to offspring? Could that possibly be an opportunity to catch that even at the earliest age? So babies that are coming up with that particular genetic makeup, maybe as early as, I know we're kind of crossing the line a little bit, as early as preteens, they can start putting that on their radar as early detection and prevention methodologies are, I guess, integrated in that process. Is that something that you see happening in the future? Having a historical overview and registry for those who are not even born yet to have that possible treatment in the future?
I love your question. So I think in newborn screening setting, I'm not an expert, but I can see this might be the ideal future. We are hoping to have a national registry and not just collecting data, do the routine surveillance, public health functions, but serve as a mechanism to allow us to do more like proactive prevention. In the cancer field, state cancer registries are already started to do more interventions. Another project we did was collaborating with Georgia State Cancer Registry, and we used their population sample to reach out to all ovarian cancer survivors in the state and encourage them, communicate about the importance of genetic counseling and genetic testing. The project just ended, and one key lesson we learned was that these community members, they may never heard about Emory University or cancer registry, so they don't have this trust with us. So for a new grant we just submitted, we incorporated engagement marketing framework, trying to identify FORCE, for example, as a national trusted intermediary to help us build the relationship and help lead the patients to learn more or even read, open our communication materials. So I think the registry is definitely a great platform for us to consider potential future preventions. And I would love to see in newborn screening setting if we can have similar systems.
It'd be great to link that together and have as we grow with our electronic medical records enhancement, AI and different other things, make sure that when that baby comes into life, that some of the possibilities, some of the probabilities, and some of the conversations to have with those parents are, it's not just a sickle cell, or it's not just a, cancer is something that can happen and possibly, probably. So yeah, possibilities are there. Thank you.
Thank you.
Yeah, since we do have a couple more minutes, do you want to comment on your thoughts on general public health genomics in terms of, I think there's a public health genomics week now, or a day we celebrate. Can you comment on some of the national efforts that are going on and your
Yeah, I can try to comment, and maybe people from the audience can also share your experiences. So I think the field of public health genomics is still relatively new. It started to get more attention in 2005 after CDC, Public Health Genomics Office, published their Tier 1 guideline recommendations. So I think with the development of new technology, with the cost of genetic testing, different kind of sequencing, the cost continue to drop, we will have a stronger and stronger evidence base to guide us which genomic applications are ready to implement at the population level. I think we are in the right direction, but to do that, my work, I have to heavily rely on people from different disciplines, so implementation science is very important, and public health practitioners are their experiences are also very important, because we are going outside the research setting and we are trying to implement it in the real world setting. So a lot of research infrastructure or support are not there, so we have to consider a lot of very practical considerations. Yeah.
Thank you. Any other comment?
I guess I would love to just mention that the issue of consent that you sort of alluded to, Ronnie, is a big problem in bringing cancer into newborn screening, or whole exome or genome, as was discussed yesterday by Dr. Brooks. People aren't consented for newborn screening, Every baby gets a newborn screen without a parental consent. Nobody gets a whole exome without a consent, or a whole genome without a consent. So to bring those two things together is going to require a paradigm shift in the way we do traditional newborn screening. I'm not sure if we asked 100 people how many of those people would want to know their whole exome in their baby at the time of birth. Probably most of them would, but many wouldn't. And
yeah, I think, again, this is a very big topic, and nobody, like we have not reached a consensus among ourselves. But one thing I want to point out is that for a long time in the US, our bioethics system are built very centralized on the individual, their benefits, their risks. But when we think about genetic risks or inherited conditions, it's not just an individual risk. So it's a shared familial risk. So experts in the field, they have proposed the notion of relational autonomy. So not just newborns, I think even for adult patients, when we think about consenting process, how we can consider the family members, their thoughts, their preferences. So maybe relying on more familial and relational based ethical principles would be beneficial, yeah.
it may be time to consider a second moment of screening when a person becomes an adult.
Yeah. Mm-hmm.
And allow them to consent for themselves what information they want. I'm not sure every 18-year-old is ready for that question, but.
Yeah, that issue has come up at least with Fragile X and other, but I also think in other countries there is that issue, the decisions are not always based, and there are countries, so in UK when they started the whole genome sequencing project, do you know anything about their consenting process?
I'm not familiar. I think for the relational autonomy, I'm more familiar about its application in the cascade testing scenario for adult patients. So there has been several studies showing like direct contact or like setting up a family account might be beneficial to facilitate consenting for not just the individual but also family members. I think involving newborns, and also involving whole genome sequencing will be a very complicated topic. Yeah.
I think we'll stop with that note. I think we can't solve that problem, but it's something. It's great for us as a group to think and dwell on and continue exploring. Thank you so much. We'll start with our next speaker, Lauren Carroll from Medical University of South Carolina. She's going to talk about evaluating the impact of tailored cohort messaging on patient participation in population-wide genome screening.
Hello everyone, I'm excited to talk to you today more about public health genomics. My name is Lauren Carroll and I recently graduated from the genetic counseling program at the Medical University of South Carolina. Which clicker am I using? This one?
Yes. Yeah.
Perfect. I have no conflicts of interest to disclose, and all the authors on my paper are affiliated with MUSC, with the exception of Dr. Caitlin Allen, who is at Wake Forest School of Medicine. The Medical University of South Carolina partnered with Helix, a population or genomics company based in California, to launch a new population-wide genomic screening program called NRDNA South Carolina in November 2021. NRDNA SC is based in South Carolina and was designed to provide no-cost genomic screening for CDC Tier 1 conditions to participants 18 years or older. CDC Tier 1 conditions include hereditary breast and ovarian cancer, Lynch syndrome, and FH, familial hypercholesterolemia. In addition to screening for the CDC Tier 1 conditions, NRDNA SC also obtains whole exome DNA sequencing data for future research and clinical applications. Study participants who are identified with either a pathogenic or likely pathogenic variant for any of the CDC Tier 1 conditions are contacted by a study staff member and offered a no-cost appointment for post-test genetic counseling. MUSC is equipped with genetic counselors specialized in both cancer and cardiovascular genetics that can discuss disease risk, medical management, and implications for family members. Enrollment is initiated by the patient through their MUSC MyChart, and there are no costs to the patient to participate. A DNA sample is collected at either an MUSC location, at a community event, or at home as requested by the participant. As of June 30th, 2025, there were more than 84,000 patients enrolled, almost 52,000 samples collected, and 900 participants have been identified with a clinically actionable result for one or more CDC Tier 1 condition. DNA recruits participants through a variety of methods: MyChart messages, community events, social media, broadcast media like television and radio, direct mail, and text messaging. In 2023, we began sending targeted messages via MyChart for patients who are scheduled for a mammogram or colonoscopy at one of 11 participating MUSC locations. Previous studies have shown that tailored health messages can improve motivation and compliance for recommended health behaviors such as clinically actionable inherited disease. The purpose of my study was to compare the two cohorts, mammography versus colonoscopy. I also wanted to examine the effect of, or the relationship with sociodemographic factors like race, ethnicity, age, and rurality with our patient outcomes. In my three outcomes, my primary outcome was enrollment, whether the patient enrolled in the study, and I had two secondary outcomes, whether they viewed the message and whether they provided a sample after they enrolled. The patient data was collected through the EHR. Patients who completed a mammogram or colonoscopy appointment between January 1st, 2024 and June 30th, 2024 were included. Since the mammography cohort was almost entirely female, males were excluded from the study. And based on these criteria, we analyzed 3,532 mammography patients and 327 colonoscopy patients. We summarized baseline demographics and clinical characteristics for all study participants. And in order to determine the relationship between the demographic characteristics and the outcomes, we used a modified Poisson regression model. To understand virality in our patient data, we matched our patient home zip code with the RUCA code, which stands for Rural Urban Commuting Area, which is data provided by the Economic Research Service, which is part of the USDA. The data set that I used had 10 RUCA codes, and since we had some really small sample sizes, we combined some of those numbers into 3 groups and called them metropolitan, micropolitan, and small town rural. Those numbers on the right are population size in those 3 groups. So we found that the patients in our study were mostly white and non-Hispanic. The majority of patients were between 40 and 70, which makes sense because that's when people are recommended to undergo mammograms, which starts at age 40 and ends at 74, and colonoscopy, which is recommended to begin at 45 and end at 75. Around a quarter of the patients viewed the message, and this was statistically the same for both cohorts. However, we did find that a significantly higher proportion of patients in the colonoscopy cohort chose to enroll in the study. When we examined the relationship between our predictor variables of age, race, ethnicity, and rurality, and our outcomes of message viewing, enrollment, and sample collection, we found that age was inversely correlated with all 3 outcomes. In addition, white patients were more likely to view the message, enroll, and submit a sample. There was no significant difference on outcomes based on ethnicity. And when we looked at rurality, we found that there was no statistically significant outcomes in message viewing. So the message was viewed across all of those rurality groups equally, but the metropolitan group was more likely to enroll than the small town rural group, and that was statistically significant. The micropolitan group, group 2, was also more likely to enroll than the small town rural group, although it didn't quite reach statistical significance. The p-value was 0.052. In this graph, you can see the decline in enrollment with each 10-year increase in age. So you may notice that we did combine some patients into age groups because there were really small sample sizes, like the 18 to 39-year-olds. This graph shows the correlation of race and outcomes. You can see viewed on the left, enrolled in the middle, and collected on the right. Here you can see the 3 groups in our rurality category. Again, there was no significance in message viewing, but there was an enrollment and collection. So consistent with previous research, we found that white patients were more likely to participate in genetic screening. Groups such as Black Americans are rightfully wary of participating in genomic studies and may need additional information about actual and perceived risks, which include discrimination, data privacy, and the emotional burden of results. Of note, the consent process for NRDNA South Carolina does address these issues, and patients who receive a positive result are offered a genetic counseling appointment. That being said, the targeted messaging could be further tailored, further refined to address some of these gaps in age, race, and rurality. There are some limitations to the study. First, we didn't track outcomes prior to initiating targeted messaging, so there was no data about the cohorts prior to the start of the intervention. Male patients were also excluded from the study, and the colonoscopy group was much smaller than the mammography group. In colonoscopy, for example, we only had 8 patients provide a sample, so some of those numbers were quite small. Future research could examine other methods of recruitment and their outcomes. We could look at a different group of patients like cardiology, since FH is one of the conditions. Future studies could include male participants to examine the effect of sex on outcomes. It could also include non-English speaking populations in the study. We could look at individual clinics. There might be clinic outliers whose patients are enrolling more frequently based on the clinic staff providing more information. We could look at patients who viewed the message but did not enroll. I was especially curious about our rural cohort because viewing the message didn't seem to be a barrier. They had the technology, but they enrolled at lesser numbers. And in addition, people who enrolled who didn't provide a sample, what was the barrier for them there? Future research could also include CDC Tier 2 conditions and see if that affects the outcomes. So I completed this research for my master's thesis project at MUSC, and I'd like to thank my thesis committee, Dr. Caitlin Allen, Sam Norman, Libby Malfris, and Kim Foyle. I'd also like to thank Nate Baker, who helped with the statistical analyses and provided guidance and education about statistics. I'd like to thank Dan Judge, who is the principal investigator, as well as the entire NRDNA and Helix teams. Thank you.
Comments, questions for Lauren?